Hey, it's Steve Kronlage from the Hand Center here to talk to you about thumb arthritis. Thumb arthritis is degeneration of the trapeziometacarpal joint. That is the joint between the trapezium, which is right here, and the first metacarpal. So basically, this joint is where the arthritis occurs. It is extremely common. It's the second most common location of arthritis in the hand. 1/4 of all women and nearly 10% of all men will have arthritis on x-ray, although not all are symptomatic. As far as symptoms are concerned, women are more symptomatic when compared to men with arthritis at a ratio of 10 to 15 to 1. The thumb is pronated and flexed 80 degrees to the plane of the palm. The thumb is underneath the fingers and it is sitting there for opposition. The trapezium forms the base of this thumb axis. It's saddle-shaped. There's an extensive reliance on soft tissue for stability. The trapeziometacarpal joint is only partially constrained due to the saddle shape. And there's a large range of motion, whether it's flexion or extension, adduction or abduction, complex opposition, pinch, and circumduction. All of these are coming through this unusually shaped saddle joint, which is relatively unstable. So who gets CMC arthritis? Well, those with ligamentous laxity, those who are female and white, Ehlers-Danlos syndrome, and then there's some literature that says men with aggressive thumb use can get thumb arthritis. But most of all, genetics play a role. Those with significant arthritis in their hands will also get thumb arthritis. But we'll see loose-jointed women with only isolated CMC joint arthritis. Patients that get thumb arthritis often will have this mechanism of degeneration where the thumb is pulled into a deduction. The thumb itself is pulled this direction and it subluxes out that direction. And when it does that, the metacarpal phalangeal joint will go into hyperextension here. The patients will lose their first web space and lose opposition. In order for this to happen, these dorsal ligaments here have to be torn. And this progresses, and patients end up using the MP joint as opposed to the CMC joint. And they're using, this patient right here has got ulnar deviation of the wrist. I'll go over that in a second. Once again, patients will push their hand into ulnar deviation. This is to compensate for that loss of web space. They'll move the entire hand in this direction to open up some sort of web space so they can use their thumb. It also prevents them from opposing their thumb, which causes pain. They move their entire hand away from their thumb instead of using their thumb. It's important to remember this when rehabbing after surgical treatment. Loose jointed people have thumb arthritis. This is well known. But does ligamentous laxity cause thumb arthritis? And if symptomatic CMC joint instability is treated, will it prevent arthritis? We don't know these answers. But we do know that traumatic carpal metacarpal joint instability will cause degeneration. So what do? We have history. Patients have activity-related pain. They have pain with pinch or grasp, and they have difficulty with caps, bottles, and activities of daily living. 30% of these patients can have carpal tunnel symptoms, and 20% can have arthritis at this joint right here as well, not just the trapeziometacarpal joint. So patients with thumb arthritis will have pain at the carpal metacarpal joint. They'll have pain with a grind, putting pressure in this direction and rotating. They can have subluxation. It's always important for us to check the MP joint right here for hyperextension, whether it's passive or with. Plain films are all that's usually needed for imaging CMC arthritis. It's good to get films of both sides, and the classification of arthritis based on severity has absolutely no correlations with patient symptoms. Sometimes patients can have severe arthritis in X-ray with minimal symptoms, sometimes minimal symptoms on x-ray, and significant symptoms. So what are non-surgical treatments for thumb arthritis? Therapeutic exercise has been shown to help with mild disease. Splints, if worn, can increase pinch strength. Anti-inflammatories are helpful. Steroid injections have been proven to work well. The question is, will hyaluronic acid, which is the same thing used in knee injections, work? There's one study out now showing that it does, but a couple that don't. This is not FDA approved. And does PRP or biologics work in the thumb? Steroids for carpal metacarpal joint arthritis have been shown to be very helpful. There's a better result, however, with less disease. But 90% of all hand surgeons surveyed use steroid injections in the management of thumb arthritis. Well, what about PRP or stem cells for thumb arthritis? I found only 2 papers published, neither of which gave me any sort of good information regarding the use of PRP. So the jury is still out and more research needs to be done. Surgical treatment for CMC arthritis. The primary indication is pain unresponsive to non-operative treatment, which is usually steroid injections and splinting. Early stage arthritis, young patients can be treated with an extension osteotomy or CMC joint arthroscopy. We're talking about patients in their 20s and 30s. It's unusual to have patients like this. Sometimes they're actually unstable and can benefit from a stabilization procedure. Later stage or older patients usually get some sort of trapeziectomy, either a hemitrapeziectomy or a whole trapeziectomy, which removes the whole trapezium, and most often some type of ligament reconstruction. We call that an LRTI. There is a historic role for arthrodesis, but this is not very commonly done, and arthroplasty is still out there and relatively uncommon. An LRTI uses a tendon to stabilize the thumb joint. Usually a full trapeziectomy, but can be half. The literature states that subsidence occurs, but is well tolerated. So why do most hand surgeons perform an LRTI? 90% of hand surgeons in the United States perform some sort of ligament reconstruction for basal thumb joint arthritis. And the reason is for subsidence. This is a paper where they looked at patients with subsidence, and they did an interposition and or an LRTI, and they had good long-term results with all of their procedures. You can see the metacarpal here has collapsed down, and the metacarpal is hitting here. This is the area where the trapezium used to be, and now it's completely collapsed. And that causes pain. It also accentuates this deformity at the metacarpal phalangeal joint as well. We have a modification of a suture suspension for our LRTIs here. We use an all-suture anchor placed in the index metacarpal base. It's brought through and holds the thumb metacarpal up, and this holds the thumb in adequate position to prevent subsidence, while the biology, which we use from a flexor tendon in the forearm to do a ligament reconstruction, heals. We also use that as a biologic interposition. We use postoperatively, the patients will be in a brace removable by 2 weeks. They'll use a short brace at 4 weeks, and by 6 weeks they have no limits. Their strength can take some time to get back, anywhere from 3 to 9 to 12 months even. But pain is usually well tolerated by 6 to 8 weeks. This is the trapezium, which will be excised. Following this, we will take suture tape, bring it through the insertion of the tendon right here, and bring it back to itself and tie it in a knot. In addition, we'll use this tendon right here and wrap it around this tendon and make a knot. And in doing so, we've recreated the biology and a different suspension technique to allow early range of motion. It's important not to forget about the joint just distal to the CMC joint or the MP joint when doing LRTIs. The hyperextension here can lead to significant postoperative problems. It's definitely accentuated with ulnar deviation of the wrist and loss of the first web space. My personal belief is that MP hyperextension can lead to a postoperative failure despite an initial good clinical correlation. Patients with lack of stability of their volar plate, or if the thumb goes backwards, even though the thumb's placed in opposition, they're still not able to use it unless it's stabilized. So if they're not treated, once again, this can lead to strength issues and pain and possible subsidence. This could be treated with a capsulodesis, which we can use another internal brace, or a fusion, but something needs to be done. This patient here will do poorly without some sort of correction because she pinches and immediately flips into hyperextension right here at the joint. And you can sort of have a clue of it right here on her first x-ray. But this patient required an MP fusion because she had no active flexion of the joint. If there's relatively normal cartilage, we can stabilize the joint and allow them to start earlier range of motion. Outcomes, key tip and pinch strength will be comparable to the other side. 90% of patients that have had an LRTI can oppose to the small finger proximal interphalangeal joint. And there's not been any proven difference in results depending on the type of procedure, trapeziectomy, hemitrapeziectomy, or ligament reconstruction. But I can tell you 90% of all hand surgeons surveyed in the United States are doing an LRTI of some sort because of those 1 or 2 patients that have subsidence. It can take a long time to fully recognize the benefits. Patients are generally quite happy, but their strength continues to improve over time. They've gotten very weak over a number of years, and it can take some time to get over that. In summary, thumb arthritis is an extremely common problem. It's more common in women than men. Non-operative treatment is effective early. Ligamentous instability and MP hyperextension needs to be addressed. And surgical treatment is effective and should be tailored to the individual. Thanks.